We've
Yes,
heard from
yes.
Dr. Ashish about safe anesthetic practices and from Dr. Rajneesh Singh about the various protocols we need to be aware of and implement for resuming elective surgeries. My job is to talk about timing of resumption of surgery, a little bit about prioritization, and or in other words, how do we go about resumption of elective surgery, and then what do we expect in terms of outcomes. So ever since the pandemic started, there have been a lot of cancellations, postponements of elective surgeries for good reason. And there have been estimates that tens of millions of surgeries have been postponed as a result of COVID. There are studies published based on surveys from various hospitals and groups. Uh, in the UK itself, 500,000 cases were expected to be cancelled or postponed within a span of 12 weeks. And this is not a phenomenon restricted to one area or one region. It is pandemic, and this is all pervasive. The global alliance named the COVID Surge Alliance, which is a major international alliance, it estimated based on a survey from 60 countries, which spanned over 510 hospitals, that within a span of 12 weeks, 28 million patients who were supposed to have elective surgeries had to either get cancelled or postponed. This included 2.3 million cancer surgeries, and I'm certain that most of you would appreciate these are cases you cannot really put off indefinitely. 72% of all patients who were supposed to be operated had faced cancellations within this 12 weeks period. So the conclusion this whole study had drawn was that for resumption of elective surgeries at certain stage, country level data will have to be taken into consideration regarding what is the status of pandemic, and then accordingly uh, we must resume surgery after the pandemic. And that was brought about in a joint statement by the American College of Surgeons along with the American Society of Anesthesiology and others. But very soon it was apparent that we cannot wait for the pandemic to be over. The realization dawned upon us that we have to learn to live with the virus, and we have to gear up to resume elective surgeries even during the pandemic. The question was when and how. And this paper that is projected right now on your screen is absolutely fresh off the press. Just day before yesterday, this debate was published in the NEJM, and this debate discussed all the various scenarios that are possible relating to resumption of elective surgeries. So in this presentation, what I am going to do is talk about when to resume elective surgery, what kind of prioritization of cases and specialties and scheduling we need to keep in mind, and then what are the outcomes? Are they any different today as compared to earlier era in terms of surgical outcomes? So talking of timing of resumption of surgery, uh, this is an issue being debated globally in our country as well. Initial thoughts were that local resumption of elective surgery should depend on the local realities. In terms of when to resume elective surgery, this can be done only after there's a sustained reduction of in new COVID cases in a specific geographical area for at least 2 weeks. And when we have demonstrated sufficient capacity in the hospital as well as in the region or state to manage the COVID pandemic very well. This includes sufficient ICU and non-ICU beds, availability of PPEs, ventilators, staff, for uncompromised care of all non-elective cases or urgent and semi-urgent cases. Such a resumption would have to be a very carefully thought of process and should be authorized by the hospital or the state and national health authorities. And this will also have to be done after there's a sufficient capacity for uncompromised care of the COVID patients across the state. This also should be taking into consideration sufficient in-hospital capacity to carry out the elective cases that we want to resume. That means after having allocated sufficient resources for COVID care, we should be left with adequate ICU, non-ICU beds, PPEs, ventilators, medications, medical and surgical supplies for the care of elective patients, and there is appropriate staff who is quite well prepared and who is in good spirit and it's not fatigued taking care of COVID patients, because the, after all, we will continue to share the staff from this very same pool to take care of both the COVID as well as non-COVID necessities in the hospital. So, having talked about when to resume, let me now talk about how do we prioritize the cases and how do we start scheduling our patients. And in this regard, again, there are elaborate guidances available from various colleges and societies. So what we the common thread which emerges out of majority of these recommendations is that there has to be a established protocol or prioritization policy which should be brought about by a prioritization policy committee, which should have inputs from surgeons, anesthesiologists, nursing staff, their leaders, and all the stakeholders. These prioritization policy committees should develop the prioritization strategy, taking into consideration certain objective priority scorings. For example, there's a scoring system called MENTS proposed by the American College. It should take into consideration such cases which were cancelled or postponed earlier. There are certain specialties or types of surgeries which need prioritization, for example, cancer and transplant, and perhaps trauma. There are certain logistic issues that need to be taken into consideration. For example, if you have to operate a patient for transplantation where live related transplant is to be done, you have to allocate 2 operating rooms simultaneously. And then identification of healthcare workers, their preparedness to undertake elective surgery, and availability of appropriate ancillary staff. And this is an example of that objective scoring system which can be used. And it's not as if this is the only prescribed system. Similar systems can be devised locally. This scoring system called the MENTS, medically necessary time-sensitive procedure scoring system, takes into consideration the procedure factors, disease factors, and the patient factors, and a combined score is then allocated to an individual case. If that case is lying in the green zone, where the anticipated surgical risk is favorable, risk to the personnel involved in the procedure is favorable, and resource utilization is also not unfavorable, then I think, and then it is thought that it is okay to proceed with this procedure. On the other hand, if the procedure involves excessive risk, surgically excessive risk to the personnel, and it would utilize excessive resources, perhaps it is better not to start or not to justify doing that procedure. Besides, strategy has to be to open the operating rooms in a phased manner. There should be some goals planned out, and based on which there can be 25% resumption of services, followed by, once 25% resumption is achieved satisfactorily, then we go on to 50% resumption, and so on. It is better to start outpatient and ambulatory surgery, or in other words, surgical procedures which are not as complex, not as risky, before we start inpatient surgeries and more complex surgeries. If we start running all the operating rooms simultaneously, it will require a lot of manpower, material, and so again makes sense to resume the surgical services in a phased manner. And then we have to strategize to optimally use the staff and the operating room time, especially in view of the kind of onslaught that might occur once you resume the services. And this may be taken care by running the OTs on the weekends or extended hours before weekends. Other things that need to be considered are the plans to address the issues relating to increased operating room volumes. Staff availability should be commensurate to the increased volumes in the OT. Other personnel availability, this includes, for example, pathology, radiology, supplies availability, for example, the anesthesia drugs, surgical consumables, surgical instruments, both disposable and non-disposable or reusable, adequate availability of inpatient beds and ICU beds or ventilators, which may be required for care of the post-operative patient. The patient may have been low risk to begin with, but may have anticipated or non-anticipated complications or sequelae of the surgical procedure, which may require ICU care. And then, while doing all this, we may have to induct or we may have to reallocate staff from other areas, and these staff who are either new or reallocated need to have appropriate training in place. So having
Gaurav, 2 more
discussed
minutes, please.
sure, sir. Let me now discuss what are the anticipated outcomes in the surgical patients in the COVID area. The surgical morbidity and mortality needs to be discussed in context of patients who are either known COVID positive or those who have recovered from COVID infection. How soon would it be appropriate to start offering elective surgery to them, and patients who have been negative always? And this also includes patients who are unknown to be COVID positive but may be COVID positive, because this realization will go a long way in counseling patients regarding uncertain outcomes and unanticipated adverse events. So there have been number of studies which have documented adverse outcomes in patients who have COVID positive disease or COVID disease, including the COVID surge collaborative study, which had reported a 24% 30-day mortality. There have been other studies which have reported high mortality rates, based on which the call for universal testing of all preoperative or surgical cases was done. And specifically in terms of cancer cases and transplant cases, specific studies and collaborative studies have been performed. But one important question that kind of remains unanswered is, how soon is it safe to start operating, or how soon after his recovery from COVID in a specific patient is it safe to operate on this patient? So this question is going to be answered by this ongoing study, which we are also part of, which is called the COVID Surge Week study, which has a primary aim to determine what is the optimal timing for surgery following SARS-CoV infection in an individual patient, and with a secondary aim to determine key global surgical indicator as postponement of surgical cases. And we hope to know that how soon would it be okay. There are a number of studies which have reported not so bad or not adverse or not unfavorable outcomes in cancer cases, including a study recently published from the Tata Memorial Center in our own country. And our own experience in the Department of Endocrine and Breast Surgery over the last 6 months, which included a very small proportion of cases compared to the last year, no more than 15% compared to last year, because we had average of approximately 10% of operating time available to us when we compare to last year. And these included majority of high-risk breast cancers and many complex endocrine tumors, including multiple endocrine neoplasia syndromes. Uh, but but what we have been able to achieve is, we had no post-operative mortality in this period, no excessive major morbidity either, and no healthcare worker infection which we can attribute to the surgical procedure. So all in all, there's been a growing body of data to document that there's no excessive or unfavorable outcome, excessive mortality or unfavorable outcomes in patients operated during these times. And these all support resumption of elective surgery now rather than waiting for the pandemic to be over. So to summarize my presentation, in order to safely resume elective procedures, elective surgical procedures during the pandemic, there has to be a well strategized, phased process in place based on the regional or national or local situations. There has to be no compromise on the safety and efficacy of patients undergoing these elective procedures. At the same time, there has to be no let up in managing the pandemic. Case prioritization is important, as I discussed, and the outcomes in elective surgical patients with appropriate strategies in place, including some scientific and administrative strategies, we can ensure not so high mortality and no excessive morbidity, major morbidity compared to the pre-pandemic era. More studies are underway to address certain gray areas, such as how soon after a patient has recovered from COVID would it be safe to operate upon him. And this is an ever changing dynamic process, and we must all engage in this process to resume elective surgery sooner than later. Thank you.